Hello and welcome to our review of the lupus literature from March. We record these podcasts for you every month, so you will always be able to keep up to date on the latest literature and expert opinions. I'm Professor Victoria Worth, Professor of Dermatology and Medicine and Chief of the Division of Dermatology at the Philadelphia VA Hospital and at University of Pennsylvania. Today I'm joined by Professor Chris Edwards, who is a consultant rheumatologist at the University Hospital Southampton NHS Foundation Trust and honorary chair of clinical rheumatology within the University of Southampton. Welcome, Chris.
Hi, Victoria. Thanks very much for inviting me to everybody to be part of this. And I think we've got two papers that we were going to discuss. And it's interesting because I guess one is about B cells and one is about interferon. And I think you were going to start with the first one, if that's right.
That is correct. I'm going to be talking about belimumab efficacy and mucocutaneous lupus erythematosus, a large post-hoc analysis from 5 phase 3 clinical trials. So, as we know, belimumab has been approved for use in systemic lupus and now in actually lupus nephritis. And we had no previous studies that really specifically looked at mucocutaneous lupus erythematosus with combining the pooled samples from these 5 phase 3 clinical trials. And this was a post hoc analysis that compiled data, again, from clinical trials to quantify the effect of belimumab on mucocutaneous manifestations of SLE in terms of improvement, sustained improvement, and prevention of flares to thereby inform recommendation for SLE management. And I would assume in management in terms of their lupus in the skin. So this post hoc analysis involved 3,086 patients with SLE. And the patients were greater than or equal to 18 years old and fulfilled ACR criteria for classification of SLE. So the patients were randomized in these different trials to a variety of lengths of time of belimumab, 1 milligram per kilo, 10 milligrams per kilo, and then standard of care. And one study was actually a subQ trial that was called Bliss SC that was added to standard of care. I think it's important to point out that what was done here was an analysis of the higher dose of the IV 10 milligram per kilo infusions. And so what you can see on the right here is one of the graphs that showed the pool mucocutaneous BILAG data from week 4 through week 52. And you can see the asterisks where they were different between placebo and the pooled treated groups. If you look at the data pretty carefully, belimumab benefits regarding the mucocutaneous BILAG-based improvement were first observed at week 12 and then extending through week 52. The belimumab benefits regarding the mucocutaneous SLEDAI-2K, which was the other measure of skin activity that was looked at in terms of these numbers of patients, showed that the first observed improvement was at week 16, as opposed to week 12 with the BILAG. And at week 52, they also observed improvement that was seen at 69.5% in the belimumab group relative to 61.4% in the placebo group. So in general, then, if you look, the 10.8% of patients on belimumab experienced at least one mucocutaneous BILAG-based flare versus 12.8% patients on placebo. And so there were differences when you looked at the treated group as a whole relative to placebo. And in particular, when you actually drill down on this, it was very clear that the patients who had more activity, such as elevated double-stranded DNA or low complements, those were the patients where you could really see the most significant difference between placebo and these reported outcomes in terms of the mucocutaneous aspects of the disease. And so it did appear in patients with more severe SLE that their skin was more typically improving when they received belimumab. And that was really the conclusion of this study. The differences were not enormous, but they really paralleled what had been done originally in the first articles showing in on order of about a 10% difference between treated and untreated patients. And so I think it's a very interesting study because just the sheer volume of patients and being able to
Mhm.
drill down in a post hoc way to look at the effects on skin of belimumab.
Yeah, and I guess some of the studies now, of newer therapies are doing more specific skin scores. So it's really interesting to go back and try and get as much information about the skin side of things from the data that already exists. It also made me think of the differences between SLEDI and BILAG as well. I have a BILAG, a bias towards BILAG, I suppose, but just looking at the amount of granularity you can get from those scores when you go back. Uh, it was also a pretty good spread of people from different backgrounds as well. There was about a third that were Asian, about a third that were from white populations. There's about just under 20%, I think, that were from black populations. And so it's a real spread of diversity across different parts of the world. Um, the other thing I thought is that one of the things you mentioned is that people that did better were the people with the highest disease activity. But also, I think it was right to say those individuals that were on the lowest steroids showed the biggest differences as well. And I thought that was interesting around when we worry about trial design and the
Mm-hmm.
importance of reducing and tapering steroids. This was something that showed that you'd see the difference more easily in a population that have tapered steroids versus not. And I thought that was an interesting point to make. The other thing that stuck here, I don't know whether I understood this before really. When you look at what was reported, alopecia was really high up. It was about 60% of the patients. And I suppose in my mind, I thought, did I really think that 60% of my patients have alopecia? I guess maybe they do, but that stuck out. I don't know whether you thought that was a high percentage or.
Yeah, I mean, that brings up it seems high. However, I think there's been a lot of interesting discussions around alopecia and what it is, because there's so many people who get a non-inflammatory diffuse alopecia that can be due to so many different things, whether it be from
Mm,
medications or from the disease itself, in terms of telogen effluvium. So it may be on average that many, and then the other thing, of course, would be more lupus specific skin lesions, discoid lupus, SCLE, that you can get in an SLE patient.
mm,
And so, it's hard to drill down on which aspect of that was present. But
yeah,
and I think also with the sleet eye, the other thing that you're sort of pointing out is just that it's either there or not there. So you have to have the rash go
yeah,
completely away to get your 2 points down. And so and that may be more than what a patient needs to feel pretty good about things. And so they may have a less than a complete response, and you're not going to pick that up on the sleet eye and still be quite satisfied. So it's a more blunt instrument, and I think that's true. But also, I think the issue about the steroid dose is really interesting, and it blunted the response, and so you couldn't see the earlier responses. Also, I think in the
mm,
patients who had higher doses of steroids, and again, pointing to the importance of designs where you get down the steroid dose as quickly as possible.
yeah. I thought that was a really interesting bit of it to see that, and it's also interesting your point about just there are so many causes of alopecia, and we're just calling it all alopecia, and without the granularity, we're just including lots of things in one group, aren't we?
Right. And I will just point out that we now do have more granular scores
Yeah,
for cutaneous lupus, such as the CLASI, which I think if we
exactly.
were going to be doing these studies now, we would maybe be seeing even greater differences between placebo and drug. And so it's a little hard to know how exactly to interpret these studies retrospectively.
Yeah. Okay, should we move on to
Yeah.
the next one? So I've
Let,
got one I was going to talk about.
yes.
So if we move on to the next slide. Okay, so this is, I mean, in some ways it is similar, and in other ways it's completely different. So we've just talked about a therapy aimed targeting B cells, and now we're aiming at a therapy that targets interferon in the form of anifrolumab. But it's a study pulling together a number of studies, so Tulip 1 and Tulip 2. We'll look at the detail of that in a moment. And looking at the concepts around treat to target and defining some of those targets as being remission by Doris criteria and also LL-DAS as well. So this is Morand et al. Low disease activity in lupus and remission attainment with anifrolumab, and as I said, involving the TULIP studies. And so they pull these things together. Now, some of this sort of data in the shorter term has been published, but this is longer term now. So this takes us out to 4 years, and we get to see the attainment of low disease activity and remission. The figure on the top right-hand side tells us about the LL-DAS, so that's the low disease activity. And some of these criteria to achieve this, they're quite high bars to get over. So the LL-DAS is like having a SLEDAI of less than 4, etc. And there are other criteria. And the DORIS, you need to have a really low, a zero SLEDAI. I think that's right. And they followed these patients up over time. They looked at the differences, and they looked at the ability to attain the low disease activity or the remission state, both by time to achieve it. And you can see from the figure on the top right, you can sort of look out to about 20 weeks. We start to see asterisks for nominal p-value differences in the low disease activity here. And then also there was some work around the percentage of time that people were in those states. And I think that gives us an idea of the volume of attainment of those low disease activity states. The other thing that's nice, and a reason to read the paper in more detail, is there's a slide that shows the percentage of time that people are in these states over time. But it does it mapping for every single individual patient that it shows. So there's lots of little lines. It almost looks like when you have those gene chip studies and you try to look at the amount of red and the amount of green, but you get to see in a very pictorial way the amount of time people are in active disease as they are at the beginning and as they go through to lower disease activity and the percentages in those. So what to say about this? So overall, you can see the difference between placebo in the top right and achievement of low disease activity state, and the p-value showing at various time points from about 20 weeks on that there was a significant difference with nominal p-values over that time. And it gives us an idea of the sort of dynamic over time and the percentage of time that individuals stay. And then the other bit about this, it just comes back to this idea of treat to target, which is well established in many diseases. Within rheumatology, it's been well established for a number of years. In rheumatoid arthritis, there's probably a bit less data to fully support it in lupus, but the thought process around if you can achieve these low disease activity states, you are more likely to do well in the long run, both from measurable endpoints, but also from patient-reported outcomes such as health-related quality of life as well. So I thought this was interesting to see, and I thought it really contrasted nicely. We had B cells, now we've got interferon. We're thinking about skin, now we're thinking about the attainment of low disease activity states.
So yeah, that's a great summary. And I think the other thing to think about in this particular comparison study is just that they seem to parallel each other, LDAS and DORIS. One of the big differences is the difference in the prednisone dose that's sort of allowed to meet the definition. Yeah. And I wondered if you wanted to maybe comment a little bit about that.
Yeah, so for the low disease activity, you have to be less than 7.5 milligrams of prednisolone. And then for the DORIS remission, you have to be less than 5 milligrams. So maybe it comes back to some of the discussion we were having with the previous paper as well, the importance of achieving that low prednisolone dose. But also it's harder. I mean, more people go into low disease activity, as you'd expect, than go into remission. It's a harder endpoint, partly because it's harder to get onto those lower doses of prednisolone as well.
And I do think that that dovetails nicely with the idea that over time, people are really becoming pretty convinced that there's no safe dose of prednisone. So there may, in fact, be a difference between 5 and 7.5 in terms of the toxicity over time.
Yeah.
And so, yeah, go ahead.
And I was just going to say, I think it's a really interesting issue at the moment. So all of my career, like many people, and the people who trained me, we've all been trying to reduce steroids, and we all agree high dose really bad, medium dose in the longer term really bad. The lower doses, it's just a bit more complicated, I think. So although I'm trying to stop it in patients, just occasionally you leave those last few milligrams
Hmm.
And there's all sorts of channeling bias in the data that says the low doses are bad. So I'm not saying we should be using steroids. I want to get rid of them. But I think that lower dose, and I hear some colleagues now talking at meetings, just pushing back a little bit about getting rid of that last few milligrams in patients. But I think this is a very interesting discussion to have, and it's probably a bit controversial as well, which is great.
Exactly. But I think, again, it speaks to the importance of having long-term data and why
Yeah,
it's important to have these kinds of studies so that we can actually, in a real world kind of way, know what's going on over time. So I think it's
yeah.
super important. So thank you for that lovely discussion. So I think that's all we have time for today. Thank you for joining me and Chris, and it's great to hear your thoughts on the latest developments in lupus management. Thank you for listening. You can find the slide decks for these papers at lupusforum.com. The Lupus Forum is free to access, and all our content is free to download. If you are not already, make sure to register for updates on the Lupus Forum. You'll receive email updates when new content is made available. You can also follow us at Lupus Forum, all one word, on Twitter, X, and LinkedIn. Thanks again, and see you next time.
Thanks very much. Goodbye.